Hi, it's Dr. Centeno, and thanks for joining us here. A little different time. Usually I'm on the weekends, on Sunday mornings, but for the next couple of weekends, I've got lectures to do where I'm going to be traveling and family things, so including this weekend. So I'm going to move this to Wednesday, Thursday evening. We'll see what works best. Obviously, when all that's done, then we'll probably go back to Sundays. So interesting topic tonight. Going to get into, what's the most likely cause of urinary frequency and urgency in a CCI patient? Because, as you know, many times I come up with these topics simply because as I'm practicing medicine, talking to patients, doing telemedicine evals, seeing patients in the office, etc., these issues come up. And so I had a patient this last week who had been told due to an abnormal SSEP test that he needed an occult tethered cord release because he had back pain and urinary symptoms. And when I looked at his lumbar MRI, had clear signs of an L5S1 problem, which can also cause urinary symptoms. So I thought it was a good idea to start talking about this and to talk about how to differentiate between these two and try to learn about this particular topic. Now, as usual, I'll go through all of this first, and then after that, you can ask questions about this topic or anything you would like. If you're at YouTube or Facebook, just go ahead and put your question in the comments, and I'll see it here. And then after this lecture on urinary urgency and CCI, I'll go ahead and get into Q&A. So let's dive into this subject first here. What's the most likely cause of urinary frequency or urgency in a CCI patient? So urinary frequency and urgency is surprisingly common in CCI patients, and also surprisingly common in just patients with garden variety low back pain, as you'll see. And the problem really here for CCI patients is that, we've got this issue of back pain and irritated nerves in your back. And then we've got this issue of occult tethered cord. And the symptoms kind of overlap. And I find that many patients who just have common low back issues that were caused by their CCI or maybe occurred independently of their CCI, because they have CCI, end up getting detethering surgery when they probably don't need it. And that's because they've got their CCI stuff, plus low back pain, bladder symptoms, abnormal urodynamic. Sometimes it's an abnormal SSEP, as you'll see, weakness in the legs, loss of sensation, etc. And my goal is simply to try and see if we can help these patients by treating their low back without having to do permanent neurosurgical changes on their central nervous system. So let's just take a 32-year-old woman with CCI who has low back pain, urinary urgency, and frequency, and kind of dissect what could be going on here with this person. So, urodynamics is often used. So it's very common for these patients to get urodynamic studies. And a urodynamic study simply means that you're monitoring the muscles of the bladder. At the same time, you're monitoring with a catheter the pressure in the bladder. And you're trying to see whether or not the bladder functions correctly. So for example, the bladder contracts and then the pelvic floor and the muscles at the valve, if you will, of the bottom of the ureter open up, and that's how you pee. And then that looks a certain way on this test. And if it's abnormal on this test, it can be due to lots of different things. But one of the things can be a problem with the nerves that are controlling all of this. And so then that's called a neurogenic bladder. And so commonly when CCI patients are diagnosed with a neurogenic bladder, what happens? What happens is that patient ends up getting the diagnosis of an occult tethered cord, and then they get detethering neurosurgery. However, all sorts of typical low back issues in patients who don't have any CCI can show abnormal urodynamics. So this is sort of the problem, right? If you can find abnormal urodynamics in people who just have back pain, and someone with CCI has back pain, who's to say that the back pain itself isn't causing that abnormal urodynamics? And that's something that I see all the time, and it's something that concerns me as a doctor, because we should be advocating for the least aggressive, least invasive thing to help our patients, not the most aggressive and invasive thing a doctor can do. So another thing is, just like this patient this week, is an abnormal SSEP. So what is an SSEP? Somatosensory evoked potential. So what does that mean? Usually for this type of SSEP, you stimulate at the tibial nerve or posterior tibial nerve here down close to the ankle. And this is a stimulator. And that signal goes up that nerve, up into the sciatic nerve, in through the spinal cord, and then eventually gets picked up really on the top of the head. So all an SSEP measures is if there's a problem somewhere in between those 2 points. It doesn't tell you where the problem is. It's one of the downsides of SSEP, is that it's super non-specific. So if you were to have a back problem in the sacral nerves, which make up part of this posterior tibial nerve, then it's going to be abnormal. If you have an occult tethered cord, it's going to be abnormal. If you have some pressure high up here on certain parts of the spinal cord in your neck or at the craniocervical junction, it's going to be abnormal. It doesn't tell you where that abnormality lives for the most part. So basically, long story short, is it really just says there's an abnormality someplace here in the wiring, we're not sure where. And that's why you can have an abnormal SSEP even if you've got just pissed off nerves in your back, having nothing to do with CCI, having nothing to do with an occult tethered cord. So let's think about this, because you might be asking yourself, how in the world could a low back issue or low back pain issue or pissed off nerves in my back have anything to do with an abnormal SSEP or urinary problems? And the answer is the sacral nerves, right? So we've got different nerves in the low back. They come out at each level here. L5 comes out here between L5 and S1, L4, L3. But then as we get down here, as we get down to the bottom, you see those red nerves, and those red nerves are the sacral nerves. And if you irritate those go to the bladder. So you're not going to really feel it necessarily in your back. You're going to feel it in your bladder. And there's a lot of women walking around and men who have urinary urgency and frequency because their sacral nerves are irritated. So what does this look like on an MRI? This is an S1 nerve. This is an S1 nerve. This is a disc bulge at L5-S1, and it's displacing that S1 or sacral nerve. There are other sacral nerves that come in after this as we go further down into the sacrum, and they can also be irritated or displaced. So if you've got any kind of issue at L5-S1, it can cause a problem with your sacral nerves and your bladder. Another clue, and this was what I saw in this particular patient's MRI, was maybe a little bit of a bulge at L5-S1, but the multifidus muscle was atrophied. Let's go back here on this one. So what does that look like here? Well, this is the low back muscle here, and then you can see very close in here, also dark muscle. So this looks pretty good, but you can see this one looks a little different here. You can see white in this area, and that's atrophy of that lumbar multifidus or stabilizing muscle there. And you can see this area in here is all white. That's complete atrophy of the stabilizing muscles. So this gives you a clue that there's an L5S1 problem. It gives you a clue that this person could have substantial issues with maybe back pain, stuff going down the legs, and urinary issues. And these are some studies that show associations between the low back and urinary symptoms. And another study that shows that oftentimes doctors are afraid to ask about this, right? You're seeing a patient for back pain, and a lot of times they won't ask about sexual issues. Do you have pain when you're having sex? They won't ask about urinary or bowel issues because they feel embarrassed to do it. They're not a urologist. They're not a proctologist. They're not, anything like that. They don't do GI work. So it's not really in their bailiwick to ask these questions, but it is very, very common that patients have these problems and doctors just aren't asking, hey, do you have urinary urgency and frequency? Because that's not what they do. They're not a urologist. So how do you know then if you have an occult tethered cord or just common everyday low back issues that need to be treated? First is a physical exam, and that's going to localize to the L5S1 area and those sacral nerves. Next is an MRI. It's going to show a central disc bulge or something going on at L5S1. It's going to show atrophy of that L5S1 multifidus. And then you can treat the area, usually with a caudal epidural with platelet growth factors, and that can get rid of the urinary symptoms. So now you know it has nothing to do with an occult tethered cord because none of these things make sense with an occult tethered cord. So you wouldn't then want to get your spinal cord detethered. It would make no sense, even if you had CCI. So again, just realize that we keep patients safe by offering the least invasive thing that's most likely to help. So for most of these people, it's going to be treating those sacral nerves. And then next, it might be stabilizing their upper neck. And then if none of that works, they can always get a surgical detethering. But once you get the surgical detethering, you can't go backwards. You've made permanent changes to the neurologic system that can never be undone. So who would be a very good candidate for detethering? We've talked about who would be a good candidate for just treating their low back. This is someone who has tried that less invasive care and it's just not working. Their bladder and bowel problems are worsening. And the low back has pretty much been ruled out as a cause of all of that. And that's the kind of person, if they meet the other criteria for an occult tethered cord, that would make sense to detether. So in summary, sacral nerve irritation in the low back is the most common cause of urinary issues in CCI patients. And this can cause abnormal urodynamics and abnormal SSEP. The best way to treat this is to inject the low back and not to cut the phylum. And if all else fails, the patient can always get a spinal cord detethering. Okay, well, let's start taking some questions here because I see we got questions coming in. Let me get rid of that and go back to the beginning here. Hannah, what structures cause dizziness and balance when looking down with CCI? Yeah, Hannah, usually it's the upper cervical spine that causes dizziness and imbalance. This is an important thing, right? The upper cervical spine is rich in proprioceptors, which is position sensors, and muscle spindles, which are things in the little suboccipital muscles here that also help with position sense. And that gets coordinated with input that comes in from the eyes and the inner ear. And that's what produces normal balance. But if one of those systems are off, like the upper neck, then you get dizzy. Now, why would you get dizzy with looking down? That's usually because of a transverse ligament issue or some laxity at the craniocervical junction. It can also be due to pressure on the medulla, but that's much less common. Most common thing is the upper neck facet joints, and it's easy to treat. You just inject those high upper neck facet joints. How concerning are dilated pupils when it's caused by CCI? not that concerning. Obviously, you want to rule out all the bad things that can cause dilated pupils. So you need to make sure the patient has a normal brain MRI, i.e. there's not some sort of brain tumor or a brain bleed or something like that. But assuming the bad things have been ruled out, it's usually irritation of the cervical sympathetic nerves that cause that pupillary dilation. And it's part of CCI complex symptoms or signs. We do see it. Carol, submitted advanced by Sherry Scott. Is there a particular diet or eating plan that we should adhere to if we're hoping to be able to get the PICL procedure at some point in the future? Yeah, I would say, Sherry, on our website, we've got the Dr. Pitt's book about a good, healthy diet, and I think that's a good diet to follow. That's going to be a low glycemic diet, lots of meat, fish, vegetables. You could call it a Mediterranean diet, low carb. That's the kind of diet you should be eating. So low sugar, low carbs, meats, fish, vegetables. And that can help with reducing chronic inflammation. Now, there are supplements that can also reduce chronic inflammation. We've got a lot of those in that stem cell support formula. Those are things like fish oil. Those are things like turmeric curcumin, glucosamine, chondroitin, those sorts of things. OG Dirty Rat, is it better to correct the cervical structure from cervical radiculopathy prior to getting PRP in the neck, or should PRP be held off while the structure is corrected, or should both be done together? Not sure what you mean by cervical structure. If what you mean by cervical structure is working on posture and working on curve correction, that's always the first thing you should try, right? Those are conservative. Now, many CCI patients can't tolerate those things, so we have to treat their CCI to get them to be able to tolerate those things. So again, try the conservative things first that don't involve injection, surgery, etc. But if that doesn't work, then get it treated, because we do see patients, even if they don't have CCI, that just can't tolerate those things until they get the nerve calmed down, for example, or the joints calmed down. And those patients would be ripe for something like an advanced PRP injection at those levels, because that's what they need to get to participate in rehab and get stronger and improve that posture. Alex, I have my PICL in less than 2 weeks, Dr. Schultz. My wife is super nervous about it. I've tried to calm her down about it, but is there anything you could say to help her ease her fear? Yeah, Alex, I mean, we treat lots and lots of CCI patients now. We have an office that's now maybe 40% CCI patients. So the entire staff is focused on that patient population. Everyone that touches the patient on the medical team knows how to deal with that patient population. The doctors obviously are highly specialized and focused on that patient population. Dr. Schultz in particular has an unbelievable bedside manner. In fact, that's one of the reasons why many years ago I joined forces with him, is we were working at the same surgery center, and I would overhear what other doctors would say to their patients, because we would cross in the surgery center, and I'd hear them in the PACU talk to their patients or pre-op. And the thing that really struck me about Dr. Schultz is how kind he was to his patients. So, you know, at the end of the day, I think she's in excellent hands. Dr. Schultz also has an incredible bedside manner, and I think he will make her feel very comfortable, and our overall team gets fantastic grades all the time, and people leave there feeling, in general, well cared for. Does CCI cause POTS symptoms, and if so, how? Yes, CCI can cause POTS symptoms. So POTS symptoms are generally tachycardia or lightheadedness, fast heart rate, when you get up too quickly, or if you change your posture from, let's say, sitting to standing, or from lying to sitting, or from lying to standing. In CCI patients, it's usually due to irritation of the vagus nerve or the cervical sympathetic nerves. And as a result, we often treat the vagus nerve or the cervical sympathetic nerves as a part of treating the CCI. Now, many times, if you just treat the CCI and reduce that extra motion, then you can reduce the irritation of those nerves and then help the POTS. But POTS symptoms are very common in CCI patients, and they commonly get better when we treat CCI. Greetings from Minnesota. Chris, my wife, submitted her pre-screen to Nalea. We have a consult with Dr. Schultz next week. She's bedroom most of the day, so we'll see if he can give us an answer. Yeah, so listen, great. We try to do the pre-screening because we want to make sure that if you take your time, energy, resources to meet with the doctor, that you'll get someplace. One of the more frustrating things that we see, obviously, is if we don't do the pre-screenings, many times we're going through the telemedicine and we can't get to a conclusion. And that's very frustrating for a patient. So we try to make sure that we have enough information to get to a conclusion with the patient, whether or not they need to do this or something else. And so that's why we do the pre-screening. Again, I think you'll love Dr. Schultz. He's got a fantastic bedside manner, and he knows his stuff when it comes to this particular area. How can the multifidus muscle be rehabbed? The multifidus muscle is a deep stabilizer. We've been talking about it today in the low back. It's also in the neck, and it atrophies there too. The best way to rehab the multifidus muscle is it usually goes south because of irritated nerves. So many times, if you try physical therapy and you can't get it to rehab, and there are deep stabilization exercises that you could do to try to rehab it, but many times you need to treat that nerve, which is putting growth factors around that nerve, in order to get the nerve to start working again, get the muscle to start firing again, and then that gets combined with a specific rehab program. Alex, I seem to feel better when I do more during the day. For example, moving more, doing more versus feeling way worse when I just sit around. I do have symptoms still, but they're way less when I move more, as long as I'm in alignment. Yeah, and that's not uncommon, right? What it means to me is that it's actually a good sign, because it means that that patient still has some muscular stability left. And if we then provide the ligamentous stability and we get rid of the things that are causing symptoms by treating those specific spots, those patients are probably going to be able to rehab more quickly than someone who can't do anything at all. So that's actually a good sign. Jamie, so if you get a detethered cord, you can't get a PICL. Doesn't necessarily mean that. We have treated detethered cord patients in the past. So I don't think there's one that has to do too much with the other. I do have a concern, however, that it does change the neurobiomechanics of the central nervous system. Having said that, there really isn't much crossover there, right? We see patients who have had their cord detethered who we treat their craniocervical instability. Obviously, we see more patients that don't. And so there really isn't a crossover between those two as far as patients who have been detethered not being PICL candidates. Ali, a 3B instability of 3.7 millimeters is mild, moderate, severe. That is mild. Having dizziness, headaches, neck pain, and dissociation daily and constant. Yeah, Ali, something to realize, and this is one of the things that maybe 6 months ago we were getting into on this channel, and we were getting into on the Reddit group, is that there isn't a direct correlation between the amount of overhang and symptoms. There was this CCI influencer guy who thought there was this direct correlation between the two. It was kind of a silly concept because there isn't. And what I mean here is that when you have about 4 millimeters of instability, that's mild, but the symptoms may not be mild. You may have more symptoms than someone who has 7 millimeters of instability. So just realize that there isn't this great correlation there. Now, what we can say is that this much is normal and that much is too much, but there isn't a great correlation between the amount of that instability and the severity of the symptoms. I wish there was. It would make my job as a doctor much, much easier and it's more simple, but there simply isn't. ES or E. Smith, can ARB blood pressure medication affect stem cell treatments? Yeah, best I can say is we know that ACE inhibitors can affect stem cell treatments. We know that because when we had patients taking lisinopril, which was very common 20 years ago, we would see culture failures on their stem cell cultures, and we weren't sure why. Several of those patients we took off of ACE inhibitors and then recultured them and had no problems. So it seemed to be a pretty consistent thing. Now, whether or not some of the newer drugs are going to do the same thing, I don't know, but I can say that lisinopril in particular was a problem. Carol Yates, been advanced by Harry Winston. If we can get to you in Colorado for the PICL procedure, how long will we need to stay before we can make an international flight home? Yeah, I've got a couple of videos on this, Harry, but at the end of the day, for international patients, I usually recommend, for instance, I do my procedures on Mondays and Tuesdays. So I would say stay the rest of the week, maybe go home over the weekend. That gives you enough time to recover for the longer international flight. It gives us a couple days to see you back in the clinic if needed. Thank you for the videos. 10 mile now, hole 1.5 deep, side of road, bounce truck side to side, caused head, left-right motion without muscle guard till late. Symptoms immediately happened. I didn't even close fingers, pain in left arm, upper mouth, sting, burn, pressure in right nose, left eye socket sore, cannot bend right toe, urge for bathroom, breathing felt off. Maybe it's in front of chest muscles. Doctor said couldn't get airplane. I don't think I have all of that, but Eric, we certainly know that traumatic car crash injuries can cause craniocervical instability, or sometimes what happens is that the body is caught unable to provide the muscular stability necessary to protect the ligaments, and then the ligaments get injured. But I don't have the whole story there. It seems like it got cut off. I have, 3.7 and 3B instability. Yeah, so not really going to be, so 3B instability is where 2 goes backwards on 3 in extension. Are adjustments going to correct that? Likely not. Certainly try upper cervical adjustments, but in general, most people would need that ligament fixed, and the only way we can get to that anterior and longitudinal ligament that high is to go through that PICL approach. Kathy, can CCI cause extra fluid in your mouth? Also, can CCI cause muscle spasms in your shoulder? CCI can affect the sympathetic parasympathetic nerves that can cause salivation. CCI may cause a spiky leaky syndrome, which can cause these small little CSF leaks that come and go. And some people describe that as fluid coming down the back of their throat. Obviously, lots of other things can cause fluid in the mouth having nothing to do with CCI. CCI can cause muscle spasms in your neck and shoulder, but lots of other things can too. So would need to know more to really say whether or not what you have is related to CCI or something else. E. Smith, I've heard peripheral nerves have the capacity to regenerate. Does this include the vagus nerve? Yeah, we have a lot of good data on the use, for example, of platelet-rich plasma and platelet growth factors on the median nerve or carpal tunnel. So I think that's good proof of concept that injecting platelet growth factors around many nerves can do the same thing. And for us, we would include the vagus nerve in that same category. That's why we do that nerve hydrodissection technique. OG, dirty rat. I did CBP for curve correction, didn't really work, caused laxity in my neck muscles. So now I've scheduled PRP procedure to help stabilize things forward. Hoping to do curve correction afterwards. Yeah, the biggest thing I would say is you need a diagnosis first. You've got to figure out, do you have a type 1 instability, a type 2 instability, a type 3 instability? And the reason I say that is if you have certain types of instability, posterior PRP is going to be a total waste of your time, energy, resources, and money. If you've got other kinds of PRP, it may be well spent, if you have other kinds of CCI, it may be money well spent. So I would say be very, very careful there, i.e. getting posterior PRP without a very specific diagnosis and knowing that that specific type of CCI maps to a good response from posterior PRP, because if you don't do that, you're going to waste a lot of time, energy, and money. BM Home Services, do you have any data that shows PICL recovery results in patients with EDS versus those without? We do. It's on my YouTube channel. So if you're watching on YouTube, then just go search the channel for EDS and it'll come up, I'm sure. Bottom line was there wasn't a big difference between those two groups last time we looked. One of the kids, CT scan shows occipitocondyle atlas on one side misaligned. My doc believes I have instability because of my symptoms. How the EPCL treat up the occipitocondyle atlas misalignment? Yeah, that's not enough for CCI diagnosis. So you would need a specific CCI diagnosis, 1A, 1C, 2A, 2B, 3A, 3B, for example. That then maps to the specific procedure. For example, if you had a CCI type 1C or sliding of the occipital condyle against the atlas, then the goal of a PICL would be to tighten that sandwich between the skull and the atlas. So that would be treating, for example, the alar ligaments, the apical ligament, the AAOM, the anterior joint capsules of the 0-1 and the posterior joint capsules of the 0-1. But again, specific diagnosis maps to specific treatment, and that requires movement-based imaging, not a CT scan. Alex, issue with BMI for procedure. Curious about airway. I know you said new mouthpiece helps. Are there any times that stop procedure these days due to it? Yeah, Alex, the good news is that the new mouthpiece has dramatically reduced our problem in treating higher BMI patients, what I call the edge cases. The old mouthpiece was good in the middle cases where you had someone that wasn't too heavy or didn't have too large of a tongue, but tended to have more difficulties in those edge use cases. We then went to the 5th generation mouthpiece. We're now on the 5.5 gen that just came out about a week ago. Both of those have dramatically reduced the issue with dealing with high BMI patients. Now, I'll never say never, but I can honestly say since I've been using the 5th generation mouthpiece, I haven't had a single patient where we had to abandon something because the airway was bad, because they were too heavy. So that doesn't mean there won't be one, but that's probably 100 patients or so, maybe not, maybe less, I don't know. But it's a lot. So I would say with the old mouthpiece, and before we got a lot of experience in how to manage some of those things, that might have been 10% of the time. Liam, hey doc, can you explain the detection when someone has CCI, but then has lower chain reaction of pain, lower in the neck or back as hips, byproduct from the CCI? Yeah, Liam, so one of the things we know is that the cervical spine is linked into lumbar stabilization. So if we're talking about a neck, low back connection, I've got some videos on it. But we know, for example, that patients with chronic neck issues can't activate they're lumbar stabilizers as well. So that's really the connection there between those two things. Vero, hello, Dr. Centeno, for a 3 millimeter translation at C23 on flexion. Generally, how many posterior PRP or Prolo injections would be needed? Yeah, a lot of that depends. That's a type 3A. That is something that responds to posterior injections. A lot of that depends on the sophistication of the provider. If you're talking about simple posterior Prolo where they're just blindly getting the ligaments or maybe using some ultrasound to get the ligaments, it's probably going to be more, 4 to 6. If you're talking about someone who's more sophisticated, they're using a combination of ultrasound, CR and fluoroscopic guidance, contrast confirmation, it's probably going to be half of that. So again, what's injected is important, but how it's injected is equally important. And providers are vastly different in their ability on how to inject. So be very, very cautious there to make sure that you're with a provider that can do high-level advanced work, not just simple ligament work, because it's going to be less expensive and fewer treatments in my experience. Jamie, do you see any correlation with patients that have autoimmune diseases like lupus or surgeons and poor outcomes with PICL? You know, Jamie, I can't say that we have a huge number of autoimmune patients in our CCI population with things like lupus, for example. So I don't know that I can state that. I haven't noticed anything that jumps out at me, i.e. every single person I've ever seen with lupus does poorly. But we also don't have a lot of them. How many hydrodissections to nerves need to stop, or maybe until nerves need to stop being pissed off? Just depends on the nerve and what else is causing it. I would say that for most of our CCI patients that are getting PICL, for example, we're doing a hydrodissection of various nerves with each procedure. Now, probably in half those patients, we end up dropping the need for that as time goes on because the nerves don't have any more problems. So how many in most patients? 2 or 3, somewhere in that range. E. Smith, can anesthesia harm the brain? I've heard certain anesthetic drugs can hurt the brain. Are the drugs used for PICL safe? Yeah, we don't use any fluorine anesthetics or inhaled gases. I think those are the ones you're talking about. We use IV sedation with Versed, usually propofol, a little bit of fentanyl for pain control. And every once in a while, we'll use a little bit of ketamine as well if the person is struggling or the person is on a lot of drugs. So at the end of the day, we don't see anesthetics like that hurting brains. Those are used, I don't know, I'm just going to make a number up, hundreds of thousands of times, at least, the United States every single year for procedures, maybe more, but I'm going to say at least hundreds of thousands of times. The vagus nerve is really long. How do you determine where to hydrodissect it? Yeah, we hydrodissect it in the neck because that's where it's getting irritated. Obviously, it goes from the upper neck area all the way down into the gut, but it's not getting irritated there in our CCI patients. So our focus is treating it where it's getting irritated by the CCI. Eddie, have a friend who has bone spurs on his neck. What can he do to remove the bones from his, or the bone spurs from his neck? Yeah, Eddie, you wouldn't want to remove the bone spurs unless they're causing problems. So bone spurs are not bad. In fact, they're good. Bone spurs help to stabilize the spine. Now, they can become bad if they're putting pressure on nerves, but if they're not putting pressure on nerves, you want to leave them alone. Taking them out can make the patient worse. Hey guys, please do me a favor, give me a like, share, comment, subscribe. I haven't asked for that yet because if you found this feed, and I know we're at a different time, so we don't have as much participation as usual, but many of our patients and CCI community are going to be watching this after the fact because it's at a strange time. And the way they're going to find it is if you give me a like, share, subscribe. If you don't, they're not going to find it. Ali, you said 3B was mild. So 2B was mild. So I apologize, Ali. When I first answered your first question, I assumed the 3.7 had to do with a 2B. For 3B, it's not mild. It's more on the moderate severe side. So for a 2B, 3.7 would be mild. For a 3B, it is not mild. Alex, what's considered high BMI? Like, what's the highest BMI you've ever done? I don't know the highest BMI we've ever done. We've certainly done BMIs of patients in their 40s, that's for sure. So anything over about 25 is considered obese. Certainly done very heavy patients. Now, listen, with any medical or surgical procedure, high BMI patients are always going to be at more risk than someone with a normal BMI. No different with this procedure, simply because anesthesia risks are higher, recovery is slower, usually need to use more anesthetic. The anesthetic tends to hang around longer because some of these anesthetics are fat soluble. Having said that, like I said, with the new mouthpiece, the issues with managing the airway in higher BMI patients have gotten much, much better. Carol's been advanced by Harry Winston. Is there any evidence that CCI can be inherited? My niece appears to have developed the same thing, and neither of us were injured. Yeah, it's a good question. Harry, the best I can say there is that HEDS is likely inherited. That's a hypermobile EDS. So that's one way that you could say that, since that's related to many CCI patients, that it could be inherited. Came across slide by chance. Thank you for your time and info. Greatly appreciated. Vera, are you familiar with DMX Center in Markham? Is it okay? It's the only place in Ontario, Canada. Yeah, we've seen some DMXs from Markham. That seems to be fine. That's one I remember because I look at a number of those. If a patient has GI issues, does CCI PICL procedure help? Or do you treat lumbar and thoracic hydrodissection? So if the GI issues are coming from irritation of the vagus nerve, like gastroparesis, and all the other causes of those GI issues have been ruled out, then yes, we see good improvement of those GI issues when we treat the CCI and the vagus nerve in the neck. Sure, Ali, sorry for the confusion between the 2B and the 3B there. Eric, when sending images, CDs, do I get them back? Eric, we really don't want your CDs. You need to upload the contents of the CD to our online server, but we don't want you to send your CDs. That's a bad idea. You want to keep those for your own record keeping. So you've got a hard copy. So you need to be able to just take the files off the CD, upload those, but we don't want your CDs. What causes brain fog and how can this be treated? Brain fog can be caused by lots and lots of different things. It is one of the symptoms of craniocervical instability. Why does it happen? Some people believe it has to do with the upper cervical spine. That research goes back to the 1920s. Some people believe, with regard to upper neck injuries, it can be related to intermittent IJV compression, to changes in CSF flow, lots of different theories. Having said that, when it's due to CCI, it pretty reliably goes away or reduces when we treat the CCI. BM home services. What can a patient do to increase the quantity and quality of their stem cells for PICL? Be as active as you're able to be, number one. Number two, eat a good, clean, healthy diet, as I described before. And number three is you might consider taking that stem cell support formula. Those are the three things I'd recommend to try to get your stem cell count as good as you can get it. Okay, I don't see any more questions. So if you've got more questions, please jump in there and put them in to ask a question. If you're on YouTube or Facebook, just put your question in the comments and I'll see it here. and then happy to answer your question, whether it's on this topic or any other topic at all. So we'll give that a minute or two. Just some housekeeping. I won't be doing this Sunday because I'll be traveling. And then for the next couple of weekends, I'm going to be traveling, doing various lectures, going to family things, a Thanksgiving in Atlanta, etc. So I'm going to be switching up the times, trying to experiment with Wednesdays, Thursday evenings, trying to find what time works the best. E. Smith, what about fasting for stem cell quantity? Yeah, there's some studies that show that stem cell quantity or quality can be impacted by fasting. So fasting for a day or two or three, I think would be just fine. I don't know that we know that for orthobiologic procedures, but there's some research that seems to connect those dots. So I think it's not an unreasonable thing to do if fasting is relatively easy for you. Thank you for your time. It's been very helpful. Happy to help. My goal here is to make sure that we get questions answered, because everyone learns from getting questions answered, even folks that are just watching and not asking questions. And do me a favor, give me a like, share, subscribe, because that's how people find this video. And many of our CCI community is going to be watching it after the fact because they may not be able to make this particular evening time. Vero, I find it difficult to differentiate the headache referred patterns because some of them overlap. They do. Is the C1-2 facet pain on the lower side skull above the suboccipital muscles, or right on the CCJ? Yeah, the biggest thing that differentiates C1, C2 facet is it's kind of like a line that goes right at the back of the skull. So if you were to take your hand and just go like that along the back of the skull, in the suboccipital region, that's what that one tends to feel like. So that one's a little bit distinct in that it's very focused in that area. Now, some of the other ones overlap quite a bit. 0-1 and 2-3, for example, overlap quite a bit with regard to the facet joints. GON tends to overlap with that, or greater occipital nerve. The lesser occipital nerve is a little bit more out in here, so that one's pretty distinct. But we can then take those pain patterns, combine that with a hands-on physical exam, and really localize what's causing that particular headache. How do we get the stem cell supplements? They're sold through the clinics. So you would want to call the Centeno Schultz Clinic, get on the schedule, then they can get you stem cell support formula. Alex, how many total procedures is the clinic up to today? Remember you said 2,500 a while back. Yes, total number of procedures, Alex. How many? It's a good question. Let's see. Best I can say is, I would say right now we're doing 500 to 700 a year, somewhere in that range. So whenever I said 2,500, you can do the calculus there. We don't necessarily keep track like that of the number of procedures we're doing, other than I can tell you what the current run rate is. Okay, guys, I am going to start winding it up because it looks like questions are winding up. If you've got any last minute questions, please jump on those. Again, give me a like, share, subscribe so other members of our CCI community can find this video, because many of them will be watching it after the fact. Ali, at 3B, can it be possible that the instability is causing jugular vagus nerve compression? Yeah, that's an interesting question. Probably less so. Having said that, it's possible, right? Usually those are more C1, C2 based instability. Having said that, you got to realize that there can be C1, C2 instability that we may not be seeing or finding. So I would say 3B less likely. 3B would, or 3A, tend to be associated more with brain fog, dizziness, imbalance, headaches, those things. Carol Yates, been advanced by Sherry Scott. In your experience, how long is the average recovery period for a PICL procedure? Yeah, for most patients, it's a bell curve. So 3 to 10 days for people in the middle. We've got people on one end that recover very quickly. Don't know that we did much. I just got an email from one of those guys. He was concerned because he didn't really have much of recovery. And we've got people on the other end who are very sensitive individuals and recover much more slowly over weeks or months. But most of the people in the middle of that bell curve are going to be 3 to 10 days. Brent, should patients wait the full 3 to 6 months of PICL healing before starting the rehab plan you've made on YouTube? No, that's too long, Brent. I would ask your doctor specifically how to tailor that for you. But for most patients, you would want to start those things at around the 4 to 6 week mark. And again, thread that needle. But again, reach out to your doctor so that your doctor can morph that number so it best fits with your particular set of clinical circumstances. Vero, where does referred facet pain come from? Is that nerves get sort of mixed up? Why does it hurt where the problem is like usual? Yeah, it's embryology. So the upper cervical and head somite, when we are embryos and developing, are one unit. And your central nervous system, therefore, looks at all of this stuff up here from C2-3 up as one thing. It doesn't differentiate it to say, this is coming from that joint of my neck or this joint in your neck. All it knows is that it's coming from somewhere in this head unit. Now, they look different, but in the embryo, they don't. They're one somite. And that's why the central nervous system gets mixed up and gets its signals mixed up. Brett, how delicate are the ligaments and facet joints in the first couple of months of a PICL? Not very. Again, I don't think you should be too concerned. That's why you sort of thread the needle, right? You have to thread the needle between getting enough activity to be able to get stronger, but not putting yourself into a big flare-up. You could wear a cervical collar, stay in bed for 3 months or 4 months, but I think you'll be worse off in the end because ultimately the ligaments won't heal as strongly because you won't have a demand on them. And at the same time, you will lose muscle stabilization. Realize that half of stabilization is from muscles, half is from ligaments. So you have to have both cylinders working to be stable. You can't prioritize the ligaments over the muscles or vice versa. Ali, sometimes when I sleep on my left side, I wake up with head pressure, dizzy feeling, and as soon as I move my head to the right, it goes way fast. That's why I'm thinking jugular compression. Could be, or that is just related, Ali, to the C2-3 facet. Again, be very, very careful with what I call rabbit holing on social media. I see patients do this all the time. That is a cervical facet instability 2-3 issue until proven otherwise. Now, I know you might have seen people online who said, oh, I think that's IJV compression, but it's not. As an expert in this space, given what you've told me, more likely than not, without knowing your clinical history, that's a 2-3 instability issue because 2-3 causes dizziness. And when it gets out of place, it's going to cause more dizziness. So the IJV doesn't have to be involved at all. The changes in weather drive me bananas. Is this CCI or IJV? Should I do PICL or chiropractor? Yeah, I can't make medical diagnoses online with tiny, tiny bits of information. That's not fair to you. It's certainly not fair to me. So when it comes to weather changes, that usually is happening because of an upper neck facet joint issue or a facet joint issue. And what happens is as low pressure fronts come through, the facet joints in the neck act as little baroreceptors. And as low pressure comes through, they expand because they've got constant pressure inside. And that swelling can cause symptoms. If it's the upper neck facets, it can cause CCI-like symptoms. So that's the best I can tell you based on that. Happy to help. Okay, guys, so we're rounding out the hour here. I'm probably going to wrap this up because I got to leave early in the morning. Again, just some housekeeping. I won't be able to do the Facebook Live this weekend. I'll be traveling for the next couple weekends, so I'm going to be doing these during the week. I'll give more time notification within the next couple of days of when we're going to do next week's Facebook Live. I want to thank everyone for the great questions. This is just wonderful because when we get good questions, other people learn. And it's not just the people online today. There's going to be hundreds of people that watch this. And many of those people are going to say, wow, that's just like me. That's the question I would have asked. So, these questions help other people in the CCI community. Brent, are there any safe devices we could use that would stimulate those deep neck muscles that won't turn on? Not really in the neck. There is a lumbar stimulator that can stimulate the multifidus muscles. I wouldn't advise it. It's an interesting idea, but it involves implanting something, and usually that's not needed. And Jonathan, poor posture causes dysautonomia. Also, will there be a correction that will relieve symptoms? Certainly, poor posture and forward head can put pressure on the upper neck, which can lead to autonomic type symptoms. An easy solution there is obviously treating the posture. Now, some patients can't do that, right? If they try to do that, they get very, very sick, or their symptoms get worse, in which case we start looking for other things like craniocervical instability. Okay, guys, I want you to have a great rest of the week. Have a great weekend, and I'll see you next week, maybe on a Wednesday and a Thursday. I'll announce that. And thank you so much for all the great questions.